While working in the ED with your seventh patient with chest pain for the day, you wonder, do I have to admit all those patients, or is there something else that I can do for them?
And the triage nurse comes and grabs you for a young lady who is 8 weeks pregnant with profuse vaginal bleeding. And you wonder, is this a threatened abortion or is this something more life-threatening?
In this episode of Critical Decisions in Emergency Medicine, we will talk about cardiovascular disorders in the ED OBS unit, specifically ACS workups, CHF, and venous thromboembolism.
We will also talk about ectopic pregnancy presentations, including common risk factors, as well as a stepwise approach to its diagnosis.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices mostly in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the July 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features such as the critical ECG, the critical procedure, as well as critical cases in orthopedics and trauma.
So for our first lesson, take heart, cardiovascular disorders in the ED OBS unit. Thank you to Drs. Meredith Busman and Evan Pasternak for writing this article.
Now, many places have an ED OBS unit, and I think the reason they were started were often for ACS workups, as well as for CHF and sometimes venous thromboembolisms.
Absolutely, but they have evolved to so much more than that, and that's what this lesson is about. We see a ton of these diagnoses in the emergency department, and the ED OBS unit, or the EDOU, is a great way to decrease the length of stay and associated costs.
So what are some common cardiovascular conditions that we can manage in these ED OBS units?
So there are several diseases, and the key to success is appropriate patient selection. A common one is ruling out patients with chest pain for ACS. And the appropriate candidates for those are the ones with a moderate heart score, 4 to 6. We all do the heart score, the history, EKG, age, risk factors, troponin. And it's important to remember that the patients with low risk can probably go home. Moderate risk, they carry a 12 to 17% 30-day risk of major adverse cardiac events, or MACE. Those are patients that would be appropriate for the EDOU. Patients with ischemic ECG changes, hypotension, troponin levels above that indeterminate range, or other active medical conditions such as sepsis or anything else are not appropriate for the EDOU.
That makes a lot of sense. Now, what about venous thromboembolisms?
So venous thromboembolism is a relatively common disease when we're talking about DVT and PE. Traditionally, we used to admit all those patients to initiate anticoagulation therapy, monitor them, and do the risk factor evaluation. Now that we have DOACs and ways to risk stratify people with PE into low risk and high risk, such as PASI, simplified PASI, or Hestia, we can just not admit all those patients. Now, some can be directly discharged home from the ED if they have good follow-up. Obviously, those with high-risk PE, like right heart strain, elevated cardiac biomarkers like your troponin or BNP, tachycardia above 110, hypoxic on room air, vasopressor dependent, patients with syncope, cardiogenic shock, a large central PE, a significant contraindication to anticoagulation, that's probably not your ED OBS unit person. Those are patients that need to be managed in an inpatient setting, perhaps even in a higher level of care. Patients who don't have those may be suitable for the ED OBS unit. Another important opportunity for the EDOU is to facilitate interventional radiology-guided thrombectomy or catheter-directed thrombolytics in patients with large lower extremity DVTs, because these interventions decrease the risk of post-thrombotic syndrome. Of course, if the patient has limb-threatening ischemia, is hemodynamically unstable, or has an extensive clot burden, that's not the patient that should be in your ED OBS unit.
Wow, that's very interesting. I never would have thought that an intervention such as thrombectomy would be a candidate for an OBS unit, but like you said, if we select the right patients.
Absolutely.
So then what about CHF?
So EDOBS unit management can be effective for moderate severity CHF exacerbation. A patient with typical CHF exacerbation symptoms is suitable, especially those with an identifiable culprit for this exacerbation. They missed their meds, they didn't have access to it, dietary indiscretions, and so on. Those that are not appropriate would be those with unstable vital signs, persistent hypotension, ongoing tachycardia despite your ED interventions, new onset hypoxia, the need for non-invasive ventilation such as BiPAP, fever, which would indicate that there's something else cooking in the background, new ischemic changes on ECG, elevated troponin, significant hyponatremia, acute kidney injury. Those are not the ones that you would think of as ED obs unit, because those are going to need one more than what you can offer into a longer stay.
Got it. Now let's go back to ACS again and talk about stress testing. Which patients benefit from urgent stress testing, and how do we determine the type of stress test?
So interestingly, if a patient has had a normal stress test within the past 12 months, repeat stress testing does not decrease their 30-day risk of MACE and doesn't really help. So really not necessary. And that time frame can be extended to 2 years if somebody has also had a CCTA that did not show any coronary stenosis, and 5 years if they had prior angiography that showed non-obstructive CAD, so less than 50% stenosis in their vessels. Because urgent repeat testing does not lead to improved clinical outcomes. When we're talking about what test to order, then the patient's disease burden really guides us, obviously, in availability in our institution. So stress echo should not be used in patients with severe COPD, AFib, decompensated heart failure, or significant pulmonary hypertension. If your patient has renal dysfunction, a history of coronary revascularization, is older than 65, then that's your patient who would do really well with a stress nuclear myocardial perfusion. If your patient has severe hypertension, like blood pressure above 200/110, or high degree AV block, then that stress nuclear myocardial perfusion testing is not suitable. A very important modality that we need to start considering more and more often, especially if you have the luxury of having it at your institution, is your CCTA or coronary CT angio. Because using a CCTA with fractional flow reserve actually decreases the number of invasive angiograms that showed non-obstructive CAD by 83%, which is just a very long way to say it has a lower false positive rate than stress testing, and therefore more efficient care. Obviously, if a patient has a contraindication to contrast dye, nitroglycerin, or beta blockade, then we can't use that modality because we need to use all those things to actually perform the CCTA. Other things are active atrial fibrillation, age older than 75, or a BMI above 40, or stents that would preclude the use of CCTA.
Got it. So let's say you go through all that, you get your diagnostic test of choice, and now you think that the patient is ready for discharge. What kind of endpoints should we consider?
So these patients may be discharged if their diagnostic testing that we got, like the CCTA or stress testing, does not show any evidence of ischemia, prior infarct, or other concerning pathology. If we find any abnormal testing results, then we need to consult cardiology to figure out what other management they need, which may include potential angiography. Of course, if throughout their observation they develop ischemic ECG changes, elevated troponins, and so on, then these patients need to be upgraded to the inpatient setup and get that workup done as needed. Of course, all of our patients should receive counseling on cardiovascular risk reduction, smoking, blood pressure, lipids, sugars, all of the good things. The other important thing, which we don't think of very often, is that if patients continue to come for chest pain over and over again, we need to screen them and help care for their anxiety, their depression, and psychosocial concerns. And of course, make sure they have a primary care doctor before they leave.
Got it. Now let's go back to VTE. You mentioned certainly we want to consider patients who are not high risk. And so what other treatments may we provide in an ED observation period?
So just like we said before, patients need to be carefully selected for this to be successful. We need to make sure that we have strict inclusion-exclusion criteria, like the SPESI, the HASTE criteria for patients with PE, to identify those that are low risk. It's also important to think of their social determinants of health that would affect their disposition. Obviously, patients who are sick, as we said before, with hypotension, tachycardia, arrhythmia, heart strain, and so on, are not appropriate individuals for this. Another important exclusion is patients who have a high risk of bleeding, because those are going to need more than what we can offer them in the ED obs unit.
Now, are there any specific pathways that we can establish for managing these VTE patients?
So obviously these patients need to be on tele, continuous pulse ox, and prompt anticoagulation should be started. And then we need to be able to order any additional testing that we need, like a leg ultrasound, an echocardiogram, as clinically indicated. And then we need to involve case management and social work to coordinate follow-up and address any access issues. Thrombophilia testing can be deferred to the outpatient setting. Now, for those patients that we were talking about earlier that need catheter-based intervention with IR, we need to consult them pretty early. Many of those may be able to return to the ED obs unit after their procedure to be observed prior to their discharge. And of course, if the patient can get DOACs, so they're not pregnant, breastfeeding, high bleeding risk, then that would be our preferable discharge medication rather than warfarin.
Okay. Are there other clinical endpoints that we should consider for discharging patients with venous thromboembolisms from the ED obs unit?
So we need to remember that some of our low-risk VTE patients can actually just be discharged directly from the ED and don't even need to go to that ED obs unit. Those patients are mostly going to be the ones who either are going to need an intervention like we talked about or have limited medication access. So as long as we're able to make those connections happen and the patient continues to be hemodynamically stable, ambulatory, and of their baseline function, then they can be discharged.
Got it. Now let's talk a little bit about CHF. We talked about patients who may be appropriate for the ED obs unit. What type of pathway should we also consider for managing these patients?
So it's important to have early aggressive diuresis starting from the emergency department, not even waiting till they get to the obs unit. They need to be continuously monitored with regular vital checks, daily weights, lab assessments. If they don't have a recent echo, then we need to repeat it if needed. And then patients need to be on a low salt, fluid restricted diet and have a clear standardized diuresis protocol to guide that treatment with the dose adjustments based on the urine output. When patients stabilize, they can be transitioned to their oral diuretics and discharged home with clear education on heart failure management and have that cardiology follow-up in place to reduce the readmissions.
Okay. Now, what about the clinical endpoints for these patients? When are they ready for discharge?
Usually it's within 24 hours, as long as the patient has symptom improvement. So they're able to lie flat, ambulate without dizziness or chest pain, and also their vital signs need to be better. So no tachycardia, no hypoxia on their usual oxygen, whether it's room air or if they're already on home oxygen. We need to do that ambulation trial, make sure they're doing well, and make sure that they have their follow-up set up and that they have what they need at home to take care of their symptoms, like, for example, a home scale for daily weights, so that they can monitor their progression and use that information to guide their follow-up. Obviously, if the patient is not responding to diuresis, if their labs are abnormal with like renal failure or significant hyponatremia, they're not getting better, then those patients need to be admitted.
Well, thank you, Danya, for taking us through this lesson. I think it's a great piece to learn a little bit about other utilizations of ED obs unit beyond ACS, which I think a lot of us are familiar with, since this can definitely decrease overall utilization, length of stay, and cost with these patients. And some of the examples the lesson provided were related to venous thromboembolisms and CHF. We have to start with, of course, appropriate patient selection, regardless of the disease process you're dealing with. And we're trying to target, of course, those who are low to moderate risk based on the disease process, because we want to be able to appropriately treat them in this limited time and, of course, have low risk of complications from this. And so for ACS, we may use a heart score to identify moderate risk patients to be, quote, ruled out for their ACS. And that may involve stress testing if that is appropriate, or increasing utilization of coronary CT angiograms. For venous thromboembolisms, we are also trying to identify those who are low risk, and you can utilize a variety of risk stratification tools, whether it is the PESI or the simplified PESI or the HESTIA criteria. And some of the treatments you can provide, of course, are initiation of anticoagulation, education related around that, workup, of course, of some of the potential related conditions with their thromboembolism, as well as in some cases, maybe even in interventions like with thrombectomy, which is a new consideration for me. And for CHF, these are a really great population to consider for EDOPS units because certainly there is potentially a subset of population who can be rapidly turned around, whether it is with missed medications or increased diuresis, etc. And so having, once again, a protocolized way to provide these interventions, as well as, again, a lot of education. And don't forget about other resources and support at the time of discharge from these OBS units, because you want to ensure the patients continue to be able to get their medications, outpatient follow-ups, etc., to succeed. So definitely check out this lesson for more clinical thresholds to help you care for these patients.
Great summary of a great lesson. So keeping up with that cardiology-esque theme, our critical ECG this month is a case of chest pain in a healthy young adult. 23-year-old, sudden chest pain an hour ago, shortness of breath, palpitations, nausea, no medical history, no non-risk factors. He's pretty tachycardic to the 130s, and you get his EKG, and it gives you chest pain because he has ST elevations in the anterior leads with reciprocal changes in the inferior leads, which go on with a STEMI. And then you're like, okay, are you sure everything's okay? And that's when your patient tells you that they used cocaine 90 minutes ago. And that explains why this person is having a cocaine-induced STEMI. This is a great reminder to not dismiss pain in younger patients, and also to remind us that in patients who are coming in with cocaine-induced myocardial infarction, then they still require immediate evaluation and activation of the STEMI pathway, because patients can still have an underlying infarct from that. In this patient, he got aspirin, he got benzos. He didn't get beta blockers because some people believe that beta blockers would cause unopposed alpha adrenergic vasoconstriction. He had an angio. He did have thrombotic occlusion in his proximal LAD and ended up with a stent. He was admitted to the ICU, treated supportively, and did well. So review the EKG and remember, 23-year-olds can also have STEMIs. Switching gears to peds, our clinical pediatrics case this month is an 8-day-old infant. And if that alone doesn't make you tachycardic, then let's listen to the rest of the story. 36-weeker at C-section for breech presentation, 5-day NICU stay due to feeding difficulty, noted by the parents to be holding the left leg in flexion with erythema and swelling over the left knee. When that knee is manipulated, baby cries. On your exam, he has an abducted left leg flexed at the hip and knee, with swelling over the distal thigh and knee, and tenderness to palpation and with range of motion. You get an x-ray, and you see a periosteal reaction on the distal femur. Blood work is unremarkable, including WBCs, ESR, and CRP. The MRI shows diffuse edema and possible Salter-Harris type 1 fracture.
As a refresher, periosteal reactions can occur from anything really where that causes the periosteum to be elevated from the cortex from any type of insult or injury. And this is more common in children because that is more reactive. And so the differential is broad. Obviously, a lot of times we think about infection, but don't forget about trauma, tumors, sometimes even medications can cause this. In this case, we started with an x-ray that showed us this periosteal reaction, but trying to characterize this more, we ultimately got an MRI because that can certainly give more useful information also about the surrounding soft tissues and the extension of the reaction.
The differential for extremity swelling in newborns includes trauma, obviously not accidental at this age, physiologic periosteal reaction of the newborns, which can be seen up to 6-month-old, osteomyelitis, non-malignant soft tissue injury, and malignancies, including osteosarcoma, Ewing sarcoma, chondroblastoma, or osteoid osteoma. So definitely a different differential than your adults. Moving on to the LLSA Literature Review. It's the article from Alcohol in 2022 entitled A Retrospective Evaluation of Phenobarbital versus Benzodiazepines for Treatment of Alcohol Withdrawal in a Regional Canadian Emergency Department.
Well, I think two takeaways from this, not only, of course, about phenobarbital, but that I wasn't aware there was a journal named Alcohol.
So I actually just double checked to make sure I read the correct journal name.
Gonna have to subscribe to that. But it is a good study to talk a little bit about, as we definitely see lots of patients with alcohol withdrawal in the EDs. And unfortunately, almost half of patients who are alcohol dependent can experience alcohol withdrawal. And it's, of course, associated with mortality that can be up to 15%. Now, we're all familiar with using benzodiazepines as it's pretty standard treatment, but of course, there's growing utilization of phenobarbital because not only does it have a longer half-life, it also has dual mechanism targeting both GABA and glutamate receptors. A lot of the studies so far have shown that as an adjunctive treatment, it can reduce admissions and improve outcomes. In this particular study, which was retrospective, compared phenobarbital versus benzodiazepine as monotherapies for treatment of alcohol withdrawal. And they looked at both ED length of stay as well as the rate of admission. Now, I want to talk a little bit about their dosing regimen, because that's always of interest. And so for phenobarbital, they used 10 milligrams per kilogram as a load, followed 1 hour later by 120 to 240 milligrams, and then additional doses titrated based on their symptoms. The benzodiazepine pathway used diazepam based on the CWA scores. So if the patient scored greater than or equal to 8, they would get an initial 10 milligram P or IV dose, followed by additional doses every 15 minutes based on their symptoms. And the study found there was no difference in ED length of stay for these patients, but those who were treated with phenobarbital were 70% less likely to be hospitalized than those treated with benzos, which is quite interesting. Of course, this phenobarbital regimen may be more aggressive than what we have seen in other studies, but the study also tried to control for more confounders. Now, a major limitation of this study was that it was small. There were only included 83 patients. And so I think it certainly just adds more information for us to consider whether or not to utilize phenobarbital in alcohol withdrawal.
Great summary of a great article. Definitely more information for us to keep using phenobarbital for alcohol withdrawal. Our critical procedure this month is intrapleural anesthesia. We usually think about it as part of placing the chest tube, but we may also consider it for pain management in rib fractures or flail chest. Obviously, there's a risk of pneumothorax, reaction to medication, introducing an infection, causing a pleural effusion, or if it's actually administered in an upright patient and gets absorbed by the diaphragm, then impaired diaphragmatic function. So think of those before you go ahead with this procedure.
Yes, indeed. Now, you would administer more anesthetic than you would just for possibly placement of your chest tube. And this feature suggests 0.3 milliliters per kilogram of 0.5% bupivacaine. You may need to give more in patients with fluid or blood in the thoracic cavity because the effects could be diminished, but just make note of your total dose to avoid anesthetic toxicity. If the patient already has a chest tube and you're giving more of the anesthetic for pain management, you would actually need to consider if you can clamp the chest tube, because you would ideally want to do that for 20 to 30 minutes to allow for absorption and not directly draining out the anesthetic you just instilled. As Danya mentioned, you would want to have the patient in a partial or fully supine position so that you can provide the appropriate anesthesia of the pleural cavity.
Something to think about in your next patient with fractures. Keeping up with broken bone situations, our critical cases in orthopedics and trauma is somebody with wrist pain.
Yeah, it's a 55-year-old man who fell 10 feet and now has wrist pain. Pretty lucky that that's their only injury, I suppose. And on your exam, you see that their wrist is swollen. There's no obvious deformity. There's diffuse tenderness, but pain with passive range of motion.
The X-ray reveals a volarly displaced lunate consistent with a lunate dislocation. It's a rare but severe carpal dislocation that occurs from high-energy mechanisms, such as a Khoujah or an MVC. And there's a high risk of median nerve compression, about 50% of patients, and also high risk of avascular necrosis. So early identification is important.
That's right. On X-ray, we're looking for the classic finding of the spilled teacup sign on lateral X-ray, where the lunate is volarly rotated and displaced and not aligned with the distal radius. On AP view, you can see a piece of pie appearance. If you're not sure, you can obtain an CT or MRI to get more details. Now, close reduction of these dislocations can be quite challenging because there's a lot of ligament disruption. And whether or not your reduction is successful, you should place the patient in a splint with the wrist in slight flexion and ulnar deviation to minimize further injury. And most of these patients are going to need surgical repair within 24 hours.
Great reminder of an important and missed injury, which I actually saw last month.
Ooh.
Interestingly, a colleague of mine saw another one that week, and I'm like, what's happening with people's lunates this week? So maybe coming near you. Our critical image this month is a 63-year-old male with interstitial lung disease and chronic diarrhea who's coming in with fatigue and vomiting. He has acute renal failure with a creatinine of 14.5, a potassium of 8, a bicarb of 12, and a pH of 7.14. Now, one thing that we need to think about is that AKI and CKD can be from post-renal or obstructive pathology, like urethral stones, strictures, or bladder outlet obstruction, which would be your prostate in men. While many patients are going to come in with acute urinary obstruction and tell you they have abdominal pain and distension, they may not really notice that, especially if we're talking about neurogenic bladder or gradually worsening BPH.
In terms of workup, the American College of Radiology recommends ultrasound as our initial imaging modality. And you can follow up with a CAT scan, CT, abdomen pelvis without contrast to further evaluate the hydronephrosis and reveal where exactly the anatomic obstruction is. The ACR also recommends avoiding potentially nephrotoxic iodinated contrast, if we believe in that, unless you cannot answer your clinical question without it. So definitely check out this case, ultrasound and CT images.
And moving on to our second lesson of this issue, out of bounds, ectopic pregnancy presentations. Thank you to Doctors Ashlyn Cooper and Parag Mehta for writing this article. We definitely think of ectopic pregnancy all the time because of the high rates of maternal and fetal morbidity and mortality. So it's an important topic to review. Let's start with the basics.
Yes. So we're talking about 1 to 2% prevalence in the US. And when we're dealing with a ruptured ectopic pregnancy, then we're dealing with up to 10% maternal mortality. Now, as a refresher, of course, an ectopic pregnancy is a gestational sac that implants outside of the endometrium, the majority of which end up in the fallopian tube, 95% or so. But there can be other sites of implantation, whether it's peritoneal or interstitial, or even in the scar tissue in the uterine wall if the patient has had a prior cesarean delivery. Don't forget that heterotopic pregnancies can occur when you have both an ectopic pregnancy and an intrauterine pregnancy. And of course, this incidence is rising with increased fertility treatments.
Great reminder of an important risk factor we forget to ask about sometimes. So what are some risk factors for ectopic pregnancy?
The scary thing is that half of these patients are not found to have any known risk factors, but the ones who do have risk factors, those we generally think about who has had prior ectopic pregnancies, some sort of fallopian tube pathology, maybe associated with pelvic inflammatory disease, as we mentioned, fertility treatments. Now, patients with IUDs have lower risk of ectopic pregnancies based on the fact that, of course, lower incidence of pregnancy. But if they do get pregnant with an IUD, then more than half of them, unfortunately, are ectopic.
Great reminders. So patients can have wide-ranging presentations of ectopic pregnancy. What are some mimics of that ectopic pregnancy presentation?
Definitely. Some of the other conditions we consider on our differential is ovarian torsion, ovarian cyst rupture, acute appendicitis, ureteral calculi, early pregnancy loss, PID, as well as trauma. Of course, if the patient has a positive pregnancy test, then that raises ectopic pregnancy higher on our differential. But just be aware that we don't want to, of course, anchor on that and need to consider, again, a broad differential.
Got it. So how do we diagnose ectopic pregnancy?
We already mentioned some of the risk factors we want to consider and ask about in the history. And then in terms of the physical exam, certainly the patient's hemodynamic status is important to consider. And then to perform a pelvic exam in all patients of childbearing age with these presenting symptoms of abdominal pain, if they have bleeding, to assess for infection, if there's any adnexal tenderness or masses, and whether the cervical os is open. In terms of labs, we know we want to get an ECG, hemoglobin, and type in screen. It's also important to remember that there's no particular level of ECG that can distinguish normal from ectopic pregnancy, but of course, lower levels and longer doubling times are more commonly seen in ectopic and other abnormal pregnancies. Ultrasound is, of course, critical in the diagnosis. If we find an empty uterus in combination with cardiac activity outside of the uterus, that is, of course, diagnostic. Most of the time, though, we're dealing with an empty uterus with maybe pelvic free fluid or mass that makes the diagnosis highly likely. And if the ultrasound is equivocal, then we want to interpret it in the context of the ECG level, also known as the discriminatory zone. And as we also may remember, a normal IUP is generally expected to be visible on a transvaginal ultrasound with an ECG level of 1500.
Important reminder of that discriminatory zone. So we got the diagnosis, we figured out it's an ectopic pregnancy. How do we treat the patient? Does everybody need surgery?
Not necessarily. Patients can be treated surgically, medically, or expectantly, and they should be individualized based on the patient's presentation and stability, what their desire for future fertility, and overall preference. If you're highly suspicious of a ruptured ectopic pregnancy, of course, you want to consult OB/GYN immediately while you're providing resuscitation and further evaluation. Don't forget that if your patient is Rh negative, you want to give the Rh immune globulin. Now, in terms of specifically on surgical interventions, historically, though, 90% of these patients were treated surgically, but now a growing number, about 40%, are treated medically. And that is with methotrexate as the first-line therapy that can be given as a single or multi-dose IM injection. The article includes a list of contraindications for methotrexate, and that includes immunodeficiency and severe anemia or thrombocytopenia. If the patient is presenting really early without any signs of rupture, you can manage them expectantly by monitoring their serial ECG. And a good number of these patients will have spontaneous resolution and do quite well. But of course, you want to make sure you counsel them on the potential risks and their return precautions.
Got it. Well, thank you, Wendy, for going through this lesson. Great refresher of an important and high-risk diagnosis. Ectopic pregnancy is important to think of, especially when patients have risk factors such as history of PID or being pregnant with an IUD in place. It's important to think of heterotopic pregnancy as well. When you have two pregnancies at the same time, ectopic and intrauterine, especially in patients with fertility treatments. Patients can present with lots of different presentations. It's important to examine their hemodynamic status and get a pelvic exam on the patient to look for adnexal tenderness or masses, get a beta HCG level as well, and a type in screen, of course. It's important to remember that there's no single HCG level that can distinguish a normal from an ectopic pregnancy. But lower levels and longer doubling times are more likely to happen with abnormal pregnancies, such as an ectopic. It's important to remember that having an empty uterus and not seeing that normal IUP on a transvaginal ultrasound with an HCG at 1500 should raise your concerns, because that would be considered the discriminatory zone. Obviously, if you see an empty uterus and cardiac activity outside the uterus, that's pretty diagnostic. If you have an empty uterus and then some pelvic free fluid or pelvic mass, that diagnosis is likely. Not all patients need surgery. It really depends on their stability, desire for future fertility, and of course, shared decision-making with a patient. If it's a ruptured ectopic, that's quite obvious. Patients need to go to surgery. However, if not, then there's a couple of options. If it's an early presentation, there's no rupture, and it's not a heterotopic pregnancy, then expectant management may be successful, especially if the initial HCG is extremely low. So definitely a conversation to have with your OBGYN and the patient to figure out how to best manage those patients. So moving on to our drug box this month, it's suzetrigine.
Yeah, I'm not sure how to pronounce it. Suzetrigine?
But it does sound nice. Suzetrigine.
That's what I'm going to call it.
I like it.
It's apparently a new non-opiate oral analgesic and targets sodium channel pain transmission. And there has been a few studies comparing hydrocodone acetaminophen with this, and it's found to be effective in reducing pain. The key consideration is that you don't want to use it with strong CYP3A inhibitors, so that includes antivirals and azoles. And some adverse effects that we may have to pay attention to are rash, muscle spasms, and elevated CK. Definitely more research is needed to help us identify the potential broader indications and long-term safety of these medications.
And last but not least, our Tox Box this month is metaldehyde toxicity. Metaldehyde is a polymer of acetaldehyde that is used as a molluscicide. That's a lot of S's and C's. But basically, you try to use it to kill mollusks like snails and slugs. And the way it works is that it decreases GABA synthesis and increases monoamino oxidase or MAO activity. It can be absorbed by the GI tract, through the skin, and by inhalation. So multimodal toxicity. And it concentrates in the CNS and the liver. Ingestions of 100 milligrams or more are associated with seizures. 400 milligrams or more are associated with coma and mortality. Patients can present with nausea, vomiting, diarrhea, dystonia, hyperreflexia. Just like all of these exposures, we need to do decontamination as early and as aggressively as possible. Dermal decontamination with soap and water, activated charcoal, to decrease intrahepatic recirculation, so even if it was not actually ingested. And then we need to treat seizures with GABA agonists, so benzos, barbiturates, and propofol. If the patient's asymptomatic, you can observe them for 6 hours and then discharge them as long as there are no other concerns.
I got nothing against snails and slugs.
Definitely not enough against them to be keeping this stuff around, but hey. So thank you, Wendy, for taking the time to go through this lesson with me. I learned a lot. Our dear listeners, we hope you enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decision publication and our podcast always informative, often enlightening, and never boring.
Follow us on social media. On Instagram, it's at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month.
Bye-bye.